Now today we are going to discuss about the hospital-acquired pneumonia and mainly focus on the ventilation associated pneumonia. Since we have discussed about the community-acquired pneumonia, I have told you about the origin of the organism, that it may be a community-acquired pneumonia, that a person come from the community with infection and he has not been into the hospital or taken antibiotic in past 3 months is known as the community-acquired pneumonia. When you come to the hospital, patient get admitted in the hospital and he or she develop infection after 48 to 72 hours after admission is known as the hospital-acquired pneumonia. If a patient get pneumonia after ventilation, then we call ventilation-associated pneumonia. And if a patient develop pneumonia in the community but he has been admitted on the hospital in previous 3 months or have been associated with the healthcare personnel or have been taking antibiotic in the community in the past 3 months and develop pneumonia is known as the healthcare associated pneumonia. According to the type, according to the origin of your pneumonia, we have the different antibiotic option and accordingly we go for our empirical treatment. If we able to diagnose definitely organism is present to us and the sensitivity, then we go according to the organism and the drug susceptibility report, and even we narrow down, we de-escalate our antibiotic from empiric to the antibiotic susceptible narrow spectrum that is left to us. Before going into the, I will just more focus on the ventilation associated pneumonia. Since ventilation associated pneumonia is developed into a ventilated patient, you have to know the pathogenesis, why a ventilated person develop this pneumonia. Before understanding that, there are the three risk factors you can say, three risk factors you can say. One is the colonization of the oropharyngeal content with the pathogenic bacteria. When you are in the community, you have your different bugs, different normal flora, but when you come to the hospital, now this has been colonized by the pathogenic bacteria. That is number one. Number two is the aspiration of that oropharyngeal content into your sterile lung region in the lower respiratory tract. Normally, when you can get aspirated, when you are lying down, you are unconscious, or when you are getting intubated, then also there will be a chance of aspiration. After intubation also, if a endotracheal tube is present inside it, it doesn't mean that there is no aspiration going on. A small amount, micro aspiration is also going on even in the intubated patient. When you are not intubated, there is a more chance of aspiration of more gastric content or more aspiration of oropharyngeal content. Since tube is not inside, then there will be macro aspiration, means huge amount of thing will get aspirated. One thing you should understand, one concept about that is when we are going to aspirate the gastric content, the stomach pH is 2. So except H. pylori, because it has the property to release ammonia around it, so it gets survive H. pylori. Other organism cannot survive in the acidic pH. So there is no chance of getting that your intestinal content or intestinal bacteria will overgrow in your stomach and then that will be aspirated. There is no chance unless you are using the pantoprazole or any PPI. Okay, so any PPI if you are using, you are lowering the gastric pH. Gastric pH you are higher, means gastric pH is raised now. Okay, so then there will be come to 7 to the neutral point where it may come to that will favor the growth of the other organism. And if a person is on PPI, pantoprazole or any proton pump inhibitor, and he get aspirated, then there is a chance of polymicrobial aspiration, but which is almost 5 in 100. Most of the patient will not come to you taking chronic proton pump inhibitor. So their gastric content pH is 2. No any organism is growing here. So the content is mainly sterile. Now if this gastric content is aspirated, then there is more chance of getting pneumonitis rather than the bacteria due to any pathogenic organism. So you should understand this thing, because why we need to understand if a person is taking pantoprazole or any proton pump inhibitor, then we have to think of the polymicrobial organism as well. If not taking, then we have to think that it may be a non-infectious cause of pneumonia as well, pneumonitis. Okay. Now let's move to the ventilation associated pneumonia. Ventilation associated pneumonia, we have talked about that it is there will be the colonization of the pathogenic organism into the in the oropharynx. Now aspiration of this gastric content, and third is this invasion, damage of your defense mechanism. I have told you there are the defense mechanism present in your body in the respiratory tract. Now when you have intubated, now your all ciliary action of your trachea and respiratory epithelium has been damaged. Okay, so now this after damage, and when we are suctioning, that also leads to a damage of the trachea and the respiratory epithelium, which leads to more colonization of the pathogenic organism. The endotracheal tube, which is present inside it in our trachea, that has two other advantages. Other disadvantages are, when this tube are present inside body, the pathogenic organism which can produce the biofilm, what is called glycocalyx, if they can form the glycocalyx, they form the biofilm around the tube. So your defense mechanism is not going to do anything on the biofilm that is on the tube. It is not on the human surface. Neither your antibiotic is going to penetrate there, because your antibiotic will go through the blood and it will remain in the tissue fluid only. So in that case, the organism is being not killed, not checked. Even the lower amount of antibiotic concentration will not going to damage, because it has formed the biofilm. And when we are going to suction again, then what will happen? There will be the dislodge of this micro droplets. This bacteria will again go to in the lower respiratory tract and cause again infection. So any person, if he or she is getting repeated infection with the same organism, you are giving the appropriate antibiotic, but also you are isolating the same organism, then you have to consider the biofilm formation into the endotracheal tube, because that is not going to improve your antibiotics. You are improving, the antibiotic is properly okay, you are giving appropriate antibiotic, but this antibiotic will only in the body fluid and tissue fluids, but it is not going onto the surface of that endotracheal tube. And also, although we can give the nebulized form of the antibiotics, but it will help in lot. It will help in some sense, but if their biofilm is heavy, then it will not be enough. That you have to consider. Okay. Then whenever a person is ventilated, and how we know that he developed pneumonia, what are the clinical features? That is important. Okay. Clinical feature is, number one is fever, leukocytosis, increased respiratory secretion. Then any physical examination, you are finding any properties or any finding of consolidation, pneumonia, or new or changing radiological infiltrate. Now let's discuss this 5 points. If there is fever can be caused due to many causes in the critical ill patient. He may have septicemia, he may have other infection, he may have UTI, he may have meningoencephalitis, anything. Or just there are a lot of cause of fever in a critical ill patient who is ventilated. Leukocytosis, same, due to the many cause, there may be a chances of leukocytosis. But when we comes to what are the two major findings, two major features will be, one is the increase in respiratory secretion. If the respiratory secretion is more, then you have to consider that there is something going wrong inside the respiratory tract. There is some infection is going inside your lung. That is number 1 point. And number 2 point is to new or changing radiological infiltrate. That's two finding, because when the patient is in ICU, in the ventilated, we usually take daily radiographic, we usually take daily X-ray. X-ray will help us to know the worsening condition. But if a patient is improving, but it will not help us to know about the clinical improvement, because even if the patient is clinically improving, the radiological changes take time. There is a lag. Patient is improving, but radiological, if you see there was not much improvement, it will take time. If clinically patient is improving, then you have to consider that appropriate therapy is right for that patient. Okay. Now, after understanding this, you have to understand one more thing, that diagnosis of VAP, ventilation associated pneumonia in ICUs are overdiagnosed. Why? Because you can see that fever may be due to a lot of cause. Okay, there may be leukocytosis may be due to a lot of cause. Even radiological infiltrate may be due to different other causes as well. Like if there is alveolar pulmonary edema, bronchial contusion, that's lung contusion is there, alveolar hemorrhage is there, hypersensitive pneumonitis is there, ARDS, pulmonary embolism. These are the features where they will have some changes in the radiological finding as well. So in that condition also will diagnose as VAP. So you have to consider this. We may overdiagnose in ICU, mainly ventilation pneumonia. Okay. Then to overcome this problem, there is the best technique is to rely on the microbiology. The microbiology diagnostic will help you more. But you have to understand one thing, that the oropharyngeal contain the lung, not the lower respiratory tract, but the upper respiratory tract are full of normal flora. If you are sending a sputum for culture, there must be some growth. Normal flora will grow. Something will grow, because this is not the sterile reason. This is the normally colonized by normal flora. So what we do? There is a term called quantitative culture. There is two culture. Qualitative means positive or not. Quantitative is if positive, what is the load? What is the load of that organism? Okay, and for knowing that load is important. Normally, if you are sending a sputum culture, and if you are sending a sputum culture, and if you found that if there is 10 to the power 6, then that is diagnostic for sputum. If you are going to take a bronchoalveolar lavage, then 10 to the power 4. If you are going to take say protected bronchial specimen, then the in culture quantitative culture should come 10 to the power 3. This load of organism must be there to say that the infection is going inside your respiratory tract. 1 ml of we'll discuss in detail in blackboard in later. First, come to know that after diagnosis, what will be the treatment option. For treatment option, you have to know what are the antibiotics that we have. Okay. So understanding this, for VAP, there are non-MDR pathogen and MDR pathogen. Okay. So the non-MDR pathogen are in the green, and they are Streptococcus pneumoniae, other streptococci, Haemophilus influenzae, methicillin sensitive staph aureus, and antibiotic sensitive Enterobacteriaceae. That is antibiotic sensitive one, E. coli, Klebsiella, Enterobacter, Cytobacter, Serratia. These are the Enterobacteriaceae that are the sensitive one. If non-MDR pathogen is responsible for the VAP, then the antibiotic that the choice will be, if no risk factor for GNP resistant, then you can go for piperacillin tazobactam, that is 4.5 gram QID or TDS. It depends upon you. If you are going to give our 4-hour infusion, then TDS is enough. 3 times is enough. That is 1 dose, give over 4-hour infusion. But if you are going to give this antibiotic only on half an hour, then you have to give 4 times. That we'll discuss later about when you come to know about the PKPD parameters and other factor about antibiotics, then we'll discuss about it. So if this non-MDR pathogen, then what will be the treatment option? The simple this is a group of antibiotic, and the both chart are from the Harrison 20th edition, and you will get that this chart in the Harrison. Okay, so there will be the piperacillin tazobactam will be number 1 choice. Otherwise, you can use cefepime or 2 gram TDS or levofloxacin 750 mg OD. So if you are finding non-MDR pathogen, then this group of antibiotic will cover that organism. But if you are finding the MDR pathogen, then you have to consider what are the MDR pathogen, like Pseudomonas aeruginosa, methicillin resistant Staphylococcus aureus, Acinetobacter species, antibiotic resistant Enterobacteriaceae like E. coli, Klebsiella, Pseudomonas, E. coli, Klebsiella, then is Proteus, Cytobacter, Enterobacter. If these are ESBL producer or carbapenem resistant organism, according to that we have to think for the antibiotic. Then the Legionella, I have told already about Legionella that it occurs only in the water system, contaminated water system, mainly through the AC. And Burkholderia, Stenotophomonas. These organisms are very much nasty and they have to be treated under ID, infectious disease consultation, most of the time. Then you can have a good outcome of that patient. And Aspergillosis species. So if this group of the organism, MDR pathogen of the organism is present, then you can't go for only one class of antibiotic. Now you have to give two antibiotics, combination of antibiotics, which includes one is beta-lactam antibiotic and another either one of aminoglycoside or quinolones or colistin or polymyxin B. So it indicates that if you have a MDR pathogen, then you have to give one beta-lactam, that may be piperacillin tazobactam or cefepime or ceftazidime or imipenem or meropenem. It depends upon you what you choose, or also the organism and the previous history of the patient, antibiotic taking history and other many factors depend. But you get one of the beta-lactam antibiotic, and with that anyone from this group, that one from either one from aminoglycoside. If you are not going to use aminoglycoside due to any reason, you go, suppose there is a renal toxicity, you cannot use amikacin, go for the quinolones group. If you cannot use, or you think that may be a resistant to the organism due to the local antibiogram of your hospital, then go for directly to the colistin or poly. But one from this plus addition of either aminoglycoside one or quinolones one or colistin poly. There should be one antibiotic from here, one antibiotic from this group. Any three groups are mentioned there, any group, one antibiotic, not one antibiotic from each. It will be piperacillin tazobactam plus poly or imipenem meropenem plus poly, anything will be. Okay, that is how you are going to manage the ventilation associated pneumonia. In addition, if you are finding very resistant bug, then sometimes you usually give the colistin nebulization to million unit freshly prepared. Okay, that nebulization can be given. Okay, other thing that you have to remember is this meropenem drug. Although some of your antibiotic has been, some of your bugs has been mentioned as carbapenem resistant, meropenem resistant, but if MIC is below less than 16, then although sensitivity MIC breakpoint is 1 only of meropenem for Enterobacteriaceae, but if it is resistant, it has been resistant, but if you have got the MIC that is 16, in that case also some of the publication has mentioned that this meropenem having MIC less than 16 can be used for that carbapenem resistant organism as well, in combination with colistin or polymyxin B. Or even if you find that you want to add one more antibiotic, the even tigecycline can be added. Regarding tigecycline, you have to understand one more thing, that tigecycline has very less concentration in the blood, almost very less concentration in the urine. In the respiratory tract also they have the concentration achieved is only its usual dose is 100 mg loading dose followed by 50 mg PD. Its usual dose is 100 mg loading dose followed by 50 PD. But at this concentration, you will achieve only the amount of drug in your respiratory tract that will kill the Streptococcus pneumoniae, Haemophilus influenzae and some atypical organism. Since it is doxycycline group so it will cover the atypical one also. But when you want to kill the MDR group of pathogens, then you have to use double the dose, that is 200 mg loading dose followed by 100 mg BD. This will be the usual dose of tigecycline if you are going to treat for the MDR pathogens of your respiratory tract. Okay, now I have talked about your pathogenesis, what are the causative organism and what are the treatment options to you. Now let me little discuss about the microbiology part, that how diagnosis is important and what are the things that you need to consider. Mainly any sample, what you have sent is sputum sample. for gram stain, and you send for gram stain and culture. In gram stain, you have to understand that if gram stain has reported pus cell greater than 25 and epithelial cell less than 10, then this is a appropriate sputum sample. This indicates that if pus cell is more, epithelial cell is less, then it indicates that your sputum sample is from the lower respiratory tract. But if you have retained pus cell less than 25 and epithelial cell greater than 10, if epithelial cell is more and pus cell is less, this indicates that your sample that has been collected from patient is only from the upper respiratory tract, and upper respiratory tract is full of normal flora. Now, any organism that grow from this kind, if you are saying is for gram stain this finding, then you don't trust the lab report. There is no point of follow the lab report, because lab report, in the lab it is been advised that if a sputum sample pus cell is less than 25 and epithelial cell is more, then do not process the sample. If you follow the guideline, then if this finding is present, then sputum should not be cultured. Although in our setting, the lab, due to lack of knowledge or due to lack of confidence, or in a sort of that they might be helpful to the clinician, they may process, but you have to decide that seeing the gram stain. Okay. Regarding culture, I have told you that culture, quantitative culture. Quantitative is not quality, it's quantity. How much quantity? Semi-quantitative is called semi-quantity culture. Same as urine infection. If you see the urine infection in 1 ml, urine UTI is called if 10 to power 5 bacteria, coloniform bacteria CFU per ml. 1 ml of urine should contain 10 to power 5 ml of bacteria. Then only you can say UTI. Same in case of sputum. 1 ml should contain 10 to the power 6 colony forming unit of per ml. So 1 ml sputum, if you have 10 to the power 6, around 10 lakh bacteria, then only we can think that there is actually respiratory tract infection is going on. If it is the normal sputum sample. If you have taken bowel sample, then it should grow at least 10 to the power 4 colony forming unit per ml. When you process 1 ml of sputum, then at least 10 to the power 4 colonies should be grown. Then only we can consider the lower respiratory tract. There is a bacteria that is ongoing multiplying and causing the infection. Okay. If it is the protected bronchial specimen, then at least 10 to the power 3 CFU per ml is required to cause there is an actual respiratory tract infection is going on. So, if you are having dilemma, if you are saying that okay, normal flora is growing in your culture and guiding you a wrong treatment, then you must consult your lab and find it out what about this semi-quantity culture and actually the total colony count, how much total colony count is growing in the culture plate of that 1 ml per 1 ml of the sputum, and it will really going to help you in managing the patient. I hope we have come to know something about the ventilation associated pneumonia and will manage in hospital and ICU settings. If there are any problem, there are many ID physician now, ID expert available in Nepal. Call me, call or anyone and get ID consultation. Thank you.